from the state, and we will start our talk today with Dr. Morad Sallam, challenging cases outside of IFU recommendations. Welcome.
Thank you very much. We will talk about this. So the title is slightly changed. I'm going to talk mainly about TEVAR in challenging proximal landing zone, and I'm going to touch on the IFU. This is what I will try to cover in the coming 50 seconds, or less than that. Landing zone challenges, IFU debate, and how much should we stick to it, and practical considerations with a couple of examples from patients that we've treated at St. Thomas's, and then to conclude that. First of all, TEVAR, or thoracic stent graft, is a tool, actually, that we use in multiple pathologies. It has been designed primarily to treat aneurysmal disease. And all of the IFU has been initially designed for aneurysmal disease rather than anything else, and been tested for that with very few exceptions of certain devices. This is what we treat. We treat aneurysmal disease, aortic dissection and acute aortic syndrome, aortic infections with mycotic aneurysms, and aortic transection in trauma. We also do treat sometimes aortitis and aortic tumors, thoracic aortic congenital disorders with occlusive disease, and sometimes a shaggy aorta or a thrombus embolizing. You might want to trap that. So multiple usage of a thoracic stent graft. This is taking us to the abdominal, to the EVAR, really, literature. And I deliberately got this one, which is a 2011 circulation publication, which was talking about failure of EVARs on the long term, but particularly the group that it is outside IFU when it's used. And this has, at the time, made a lot of restrictions, and people started to kind of, should we stick to IFU? Should we think about it a little bit differently? But what was striking at the time, and this is about abdominal rather than thoracic, is that 42 to 69% in this meta-analysis were compliant with IFU, depending on how strict you would apply the IFU to the scans that you would see, which is quite a big number. Years down the line, last year in PAVSS, I presented a bit of a debate on whether we should stick to IFU or not. And I have to say, I couldn't find a very definitive answer, tried to be on the balance. But what I found in the literature, that at least 30% of the current abdominal EVARs implanted and published in literature are outside IFU. This is a shocking number, quite a big one. And the debate will carry on until we have better data. But generally speaking, I wouldn't recommend that we use devices outside IFU. They are made for a reason. It is safer to comply with the manufacturer advice, and not because it fits, it will work well. Having said that, there are many practical considerations. We are professionals here, and with multiple or different levels of experience and seniority. And you can see here that what are you going to do with emergency? What are you going to do in bailout unplanned? What are you going to do if you have lots of expertise and you want to push the limit with what you have? And finally, you are sometimes restricted by financial constraints and resources. So you will have to consider outside the IFU. Just keep the patient best interest in the middle and start to think about that. And moving on. Challenging landing zone. I would move here on the challenging landing zone and highlight that arch anatomy can make it very difficult. The different types of arch, how steep is it, is one of the most important challenges. Then the aortic pathology, whether it is a dissection, very friable, hot aorta, or it is an aneurysmal disease full of plaque in the arch. This is another type of a challenge. The length and the quality, which we talk about most, is mainly designed for aneurysmal disease, the 2 centimeter parallel walls of the aorta. And finally, the location. Where exactly are you landing? Are you landing in zone 1, 2, or 3, or maybe zone 0? And the axis sometimes restrict and make even your landing zone a little bit difficult. So the TEVAR for thoracic aortic aneurysm with a 2 centimeter healthy segment of the aorta, you can extend that by some of the neck debranching, or you can create a frozen elephant trunk, or you can land in a total arch repair. All of these are ways to achieve a better landing zone. Now, this is a lady who is 78-year-old, came with a symptomatic 8 centimeter with a pain, rapid expansion. Most of the aneurysm was on the outer curve, just distal to the left subclavian, quite high in the apex of the lung. And actually, she had some compression symptoms and hypertension, ischemic heart disease, osteoarthritic, but good quality of life, with a very small left vertebral artery and a short landing zone. It's not very short, 18 is acceptable, but with this huge aneurysm that goes from a neck, it was a bit of a difficulty. What I want to highlight here is the difficulty was the right projection to separate innominate carotid and subclavian to see the landing zone without having parallax in the graft. So we ended up putting a Gore graft, which slipped a little bit on deployment. And I think part of it, we were a little bit distal, and the other part was just because of the deployment. We didn't take all of the tension. So we went with a wire from the right arm and cannulated the right carotid to create a landing zone marker here. And we've gone very aggressive on this reverse conical neck and left the barbs across the left carotid. I have to say, coming through an already deployed TEVAR here made the track for the next one a bit easier and took some of the energy out. And we landed the fabric just at the edge of the left carotid, maximized the landing zone, and used the 18 millimeter. Another one is a TEVAR for a mycotic aneurysm, and this is a little bit unusual. 64, female, thymectomy, chronic sternal osteomyelitis, and with an open wound. As you can see, this sinus was bleeding all the way to theater, ended up being done as a semi-emergency with a bit of compression on the floor. And we decided here to go with a Gore abdominal cuff. So we used an excluder, 45 millimeters, just because of the length from the coronaries to the innominate. It couldn't have taken anything more than that. With access from the axillary artery, and we ended up landing the rapid pacing. You can see here that the graft is being deployed. We came from the axillary because the delivery system doesn't get you from the femoral up all the way to the coronaries. And we deployed it on the rapid pacing wires and ended up with this. It is fair to say that she was turned down for open repair because of porcine aorta, massive infection. She's not treated because she still has infection. I just debrided her and put VAC 2 weeks ago. And let's hope what we can get through, but at least she's sealed completely and she doesn't bleed anymore from the sternum. This is another one that came just after. I just want to show you the pulsatile mass. Sorry, this is a little bit, we can skip that one. So she came with a pulsatile mass. So ascending cuffs are not very new to the literature. There are few that have been done all in a bit of an experimental, all outside IFU and all as bailouts, and they should be considered. The type B dissection can be more and more tricky, and I just wanted to highlight here that the person holding the wire is extremely important. This graft is in a very dangerous position now with the barbs on the unhealthy arch because the wire is a little bit slipped. And this is much better as the wire goes on, and we got it across to maximize and minimize the risk of a retrograde type A. Finally, there's a lot here about planning that need to be kept in mind. The oversizing depending on the pathology, any future procedures, the access, projection and angulation, especially for steep arch, and the device choice and bailout all need to be considered. The last thing I would like to say about TEVARs here is that physiology matters. So it's not really a tube that we are putting in, and we are understanding as we come closer to the heart that the current technology that we have as a tube is probably not going to work as well as it worked in the infrarenal and descending thoracic. We need something to respect the arch, not only anatomy, physiology and pulsatile flow, and a lot of evidence is coming up on that. When I started, I thought we were here. I think we are dropped down now a little bit more, knowing a bit more about thoracic disease and endovascular, and we are on the up curve of learning. Thank you.